All right. Well, hello, everyone. I hope your morning sessions have been going awesomely. I'm super excited about this next panel presentation, Machine Learning and Precision Medicine in Emergency Medicine, the basics. And we have a great team for you today, and I'll let them all introduce themselves, and I'll be here moderating if you have any questions, and I'll bring them up to the panel at the end. So without further ado, take it away, guys.
All right.
Next slide. Oh, go.
Great. Yeah, sorry.
Hi, good morning. I'm Ross Fleischman from Harbor UCLA. Next slide. And I'd like to begin with a conventional definition of artificial intelligence as the idea of using computers to do things that would normally require human intelligence. Next slide. And contrast that with the computerized decision support that many of us know and love from our electronic health records, such as this sepsis alert that basically looks at some very simple criteria, some vital signs, looks for a few lab values that suggest organ dysfunction, looks for some discretely documented diagnoses that then might modify how the other criteria are used, and then fires an alert. So to my mind, this is sort of like teaching a dog to walk on its hind legs. Yes, the dog will do it, but it doesn't do very well. And next slide. If you're going to train a dog to do something, let's train it to do something that only a dog can do, such as use its powerful nose to find a missing person. Because in many ways, the computer or the dog is more powerful than us. While that model looked at 17 simple criteria, computer can easily look at thousands or hundreds of thousands of data points. Computers are also a lot better at looking at trends, for example, changes in vital signs over time, or can find relationships between variables, for example, diagnoses and lab values that would not be apparent to us. So in a supervised machine learning model, basically what we're doing is we are taking a whole bunch of patients who we know to be septic or not septic. We give the computer access to that as well as a whole bunch of the information in the clinical health record, put that all into the box. It's called a gray box because it's not truly black. And then the computer in its own way sniffs out if the patient is likely to be septic or not septic. So I would like to think of AI not just as teaching computers to think like us, but really to think better than us using the way that they can do things like the dog with its nose that we can't. Next slide. So one thing that I was interested in as an operational person is where we are in terms of actually implementing these great things we're going to hear about in the next 5 parts. So I looked at this nice scoping review done looking at all of the AI AI projects published that were relevant to emergency medicine and looked at the citations just from 2018 through February of 2020. I read through the methods on all these to see, are these actually implemented or what? And sadly, I found that of 20 papers I reviewed, all but one were using exported data that had been taken out and cleaned and run through the models, and only one was actually really implemented in the electronic health record. So it shows how far our field still has to go, because just setting up these machine learning models is only a small part of the challenge. Almost the bigger part is actually getting that data to work in the electronic health record, getting it clean enough that these models and tools can run. So it'll be very interesting to see in the next few years what progress we make on that. Will it be the big EHR vendors, Cerner and Epic, who make these interfaces for doing machine learning and AI implementations? Will it be third-party commercial vendors, or will it be academic researchers who take this from the computer science lab to the clinic? And so, next slide. With that, we will now move on to hearing 5 experts, each describe the details of their area of expertise. On to Andrew. Thank you. And we will take questions at the end.
Thanks, Ross. So hey, everyone. I'm Andrew Taylor. I'm an emergency physician at Yale and data science researcher. My kind of task is to give you a general kind of overview of machine learning and give you kind of an understanding of why kind of machine learning is so powerful and why people are so enthusiastic about using it. So I think the first thing to start with is just, what's the definition of machine learning and kind of how is that different from statistics? And I have to say that they do have a significant amount of overlap, and some of it is just the perspective that you take into a particular problem. That being said, machine learning algorithms or approaches tend to kind of be more general purpose. They tend to not make a lot of assumptions about the kind of data generating process, so about the underlying kind of distributions of the data. And they tend to be focused on problems that may have kind of rich or unwieldy data, such as imaging data or text data or other things like that. Next slide. And so where are the kind of areas you would use machine learning models? So one is in focused areas where you're really concerned about model accuracy. For the most part, if you look in the general literature, now machine learning models consistently outperform kind of standard, what we would consider logistic regression models and kind of more traditional models. The other areas is in that kind of area where I had mentioned before is kind of in multimodal or non-traditional data sets. So that would be text, images, graph-like data. They're also very helpful when you have computational constraints, and this can be from the size of the data, whether you have millions of samples or tens to hundreds of thousands of features within a data set. There are aspects of machine learning algorithms that facilitate learning kind of in those types of environments. And then the last, and I think maybe even the most important, is the kind of the goal of capturing complex nonlinear relationships between variables. And this kind of gets to the heart of kind of feature discovery and using those features to make predictions. Next slide. So this just gives you kind of a high level overview of, I think, the steps. And Ross had kind of alluded to kind of where we are from an AI machine learning kind of state, particularly within emergency medicine. And really, if you look at the top part of this, with the feature discover, model development, and algorithmic bias and maintenance. So these are kind of things that you would think that like a data scientist would be working on. And I would have to say, for those particular aspects of things, really right now where we are from a science perspective is really just kind of in the feature discovery and model development. There's not been a lot of work in the past on algorithmic bias, and there's not a lot of work on continuing maintenance of algorithms and models within systems. But then there's a whole other aspect of machine learning, which is, I think, this kind of interface between doctors and those data scientists. And there's this aspect of interpretability and building models that people can understand and use. There are aspects of implementation, and that's working with stakeholders within the hospital or operational people to be able to get these models into practice. There's a big component that hasn't been really used significantly so far, but I think is coming soon, which is really having rigorous methods for evaluation. So whether that's randomized controlled trials and deploying these types of ML models. And then lastly is the whole issue of kind of dissemination and making these models available for everybody to be able to use. Next slide. So the traditional kind of machine learning task can be broken into 5 really components. The first 2, classification and regression, are really just supervised learning methods. So where you have some type of label and you're training the machine learning model to be able to use that. An unsupervised technique is when you don't have a label, but you're using some type of intrinsic property of the data to be able to learn something. And that the most kind of classic example of that would be clustering or finding groups within data. And that's typically now used for like computational phenotypes if you want to find like subgroups of diabetes patients or things like that. Reinforcement learning is something that we often don't use a lot, but is used in a lot of other different fields. And it's this idea where you have an agent and they have a kind of a reward system and they go through a series of tasks. Often these are used in kind of like game-like environments, and those tasks and feedback rewards, and they're trying to optimize kind of that process. And then lastly, in semi-supervised learning, it's kind of a combination of unsupervised and supervised, where you have some labeled data, but all of your data is not labeled. And as an example of that, it might be, that you have a large data set of CT imaging, and but only 1,000 out of the 50,000 CT images actually have labels for some particular outcome. And this is all kind of wrapped into this process of where you have data, you have a particular objective, you have some type of learning algorithm, and you have some optimization process that you're going through. Next slide. So the last kind of part I'm going to focus on is just this concept of representational learning. And I think this is really kind of the heart of kind of what machine learning algorithms, and particularly like deep learning algorithms, which we're going to talk a little bit about in the future kind of components of this talk, but they're really kind of what they're getting at. And the idea behind this is that, we have all kinds of weird regular data structures that we might encounter that aren't kind of in the traditional data sets. So, whether that's imaging data, whether that's time series data, whether that's irregular data structures like graphs. And, it's tough to be able to figure out kind of what are the features that are going to be helpful in making a particular decision. And so representational learning is another way of framing it would be kind of a feature learning component of these machine learning models. And we'll talk a little bit about that. Next slide. So the other kind of big concept I wanted to throw out there is the decision space concept. If you can look on the far left-hand side, I know these pictures are a little small, but if you consider the kind of red people without sepsis and the blue people with sepsis, and then the x-axis being heart rate and the kind of y-axis on this being blood pressure, then you can kind of think of like these algorithms trying to divide up the data space to be able to make a decision. And this is typically framed in a decision space kind of framework. And a lot of representational learning is trying to fit data into a space that you then can make decisions. Next slide. So I'm going to give you a very basic example. And this is really at the heart of kind of what deep learning is and everything else. So you may think it's super complicated, but I think hopefully after you see this, you won't think it's too complicated. So we're going to take a very simple example. We're trying to predict sepsis. We have a binary outcome. You have two inputs, heart rate and systolic blood pressure. And in typical like a logistic regression model, you're going to have the coefficients that are associated with that. And you can kind of see the equation there below where you have some combination of heart rate and systolic blood pressure is going to be able to get you to your prediction. Next slide. And really the critical step of kind of representational learning and deep learning is that you throw in these kind of middle components, which are often called hidden layers within that. And if you'll take a look just at A, we'll take the node A at the very top there. So node A in this kind of model is representative of some combination of the heart rate and systolic blood pressure. And then ultimately node A and node B and node C are then combined into an output. And if you look at node A, what it really is some kind of combination of heart rate and systolic blood pressure together. And so we have this new feature. And so effectively what that hidden layer is, it's a new feature space. It's a combination of the other features that we've used in the past to be able to make a new prediction. And then you'll see at the very end step, really the decision is just being made out of kind of a linear decision of the new features that we learned. So both A, B, and C. Next slide. And so basically what you're learning is some function that takes you from an input space that kind of gets the features into a better situation, and then you make a decision about whether it's going to be sepsis or no sepsis. Next slide. And so lastly, in a very more complicated example, this is exactly how deep learning works for images. You take a medical image, you have multiple layers in the middle that learn these kind of complex features from the data. And then they have a final kind of layer, which you can see is in layer 5 there, that has these really kind of complex features. And then you make a prediction about whether there's a cat or dog. Next slide. Okay, so we're going to now move on to part 2. So we got kind of the high level overview, and we're going to move on to some short presentations in particular applications. Next slide.
Hello, everyone. My name is Sam Lam, and I work at a Southern Medical Center in Sacramento, California. And for the next few minutes, I'm going to be talking about the AI applications in imaging pertaining to the practice of emergency medicine. First, we're going to define a few terms, actually building what Andrew's already talked about before. Deep learning, it's a branch of machine learning. Deep learning is a branch of machine learning, which is in turn a branch of artificial intelligence. And it refers to utilization of layer neural networks for unsupervised learning. A neural network, it's actually layers of nodes, or if you want to think in biological terms, neurons, each performing a computational operation, generating an output to the next layer, eventually leading to a final output. Convolutional neural network, or CNN, it's a neural network that uses a mathematical operation called convolution that is particularly suited for processing imaging data. And you would see it mentioned in a lot of the imaging applications. Next slide, please. I'm going to start with POCUS first because my day job, it's a POCUS director at my shop. And when I try to get my docs to do more POCUS, the excuses for naysayers are usually along the lines of I'm too old to do ultrasound, or ultrasound's too operator dependent, or I don't do enough to feel comfortable to interpret ultrasound. So I think AI may be finally the solution that we're hoping for the more popular use of ultrasound in the ED setting, and for the following reasons. And I would give you some examples of each. Next slide, please. So here's an example of a problem I face on a regular basis. Somebody took an ultrasound picture of the body cavity, and I had to go back in the chart and try to figure out what that is and give them credit for doing that ultrasound. So to solve that problem, Mike Blivis and colleague created a deep learning algorithm to kind of sort images, ultrasound focused images, into different categories. And they were moderately successful in doing that, achieving about 70% accuracy. It's not as good as the experts who achieve about 90+% accuracies. However, it takes a lot less time than the experts to do so. And by the way, the picture up there is actually a picture of an aortic aneurysm. And that's not intuitive if you just look at a picture by itself without labeling. So what's the implication of that? So if I have access to an AI algorithm like that, it can act as a sorting hat and help me quickly just sort through some of the record images for QA and credentialing purposes. And to take it to the next step, a good AI package can even help me do competency assessment by comparing acquired images to predefined standards and help with learner classifications. Next slide, please. In another study, Blivis and colleague created another deep learning algorithm to identify and label landmarks in POCUS images for vascular access training. And in that case, they achieved an AUC, or area under curve, of 0.78, which is compatible to those of the expert reviewers. And the practical implication of that is that you can use this algorithm, and preferably available in real time, to fine-tune the learner skills by pointing out what they're seeing on the images and hopefully give them confidence to do more and be more hands-on. And of course, that's in addition to the hands-on instruction to provide, but it is a great addition to what you can do to enhance learner skills. Next slide, please. Going from POCUS to a related field, which is echocardiography, there has been tremendous development in AI and echocardiography as well. For example, there has been an AI package out there to help guide image acquisition in ultrasonographers. In the image below, the user is trying to get a picture of the peristonal long axis of the heart, and the computer will look at the images and kind of give you some tips on how to get a good image. In this case, you would like to move your probe to the left side. And the more the image approximates the perfect ideal image, the more the gauge on the left fills up, until eventually it's a checkbox that comes on that automatically records the image for you. So pretty nifty package out there, and it's in real time too. There are other AI packages out there for echo that would let you measure EF, wall thickness, wall motion abnormalities, ventricular function, assess valvular function, and there are definitely some deep learning algorithms that allow you to do more advanced diagnoses, such as diastolic heart failure, cardiomyopathy, amyloidosis, and pulmonary hypertension. And you can see that practical application of all these AI softwares. A good AI program on the point of care ultrasound machine can help identify landmarks in real time and really just help guide image acquisition to users of all levels, and really just popularized the use of POCUS in the ED setting. And if you have a program that provides quick measurement of key parameters on POCUS images, it can certainly help guide clinical decision-making in real time as well, and will be tremendously helpful in the remote or mass casualty or austere environment. Going from echocardiology to diagnostic imaging, there has been tremendous advance in that field as well. Now there are AI packages to help diagnose stroke, intracranial bleed, PE, to diagnose TB and pneumonia on chest X-ray, to diagnose fracture on plain films, and of course diagnose COVID-19 in chest CT and chest X-ray. In fact, AI in diagnostic imaging is so advanced that nowadays there are commercially available FDA-approved softwares that help with the workflow of radiologists. And here's an example of the radiologist software. The screen that you see on the software on the top part that would highlight some of the abnormal images for you. So pick out the abnormal images and highlight it and move it to the top of the queue so that they get read in priority in preference to other images. In addition, they can generate some computer error signs for diagnoses such as intracranial bleed or PE or cervical spine fracture to allow the radiologist to kind of focus on the higher areas and lighten the cognitive load. So I don't have a lot of time, but I can only provide very short glimpse of what's available in AI technology imaging, but I hope it gives you a sense of what are the technology out there and how much advance AI has made over the last 2 decades or so. And hopefully some of the technology will trickle down to the ED setting and help make our practice easier. Thank you.
Hi, I'm Catherine Staten. I'm an associate professor of emergency medicine and global health at Duke University. And my affiliation with the Duke Global Health Institute sort of lends for the platform for which we're going to talk about the next two, which are text mining and natural language processing, as well as geographic information systems. So starting with NLP. So why use text? We talked about this a little bit before, but text is a very unstructured format. And a lot of the times it's not a checkbox. We're not able to organize it or categorize it. We have no idea what's in there, but there's a lot of really useful information in there. I'll give you an example. Pre-hospital care systems internationally have a ton of chief complaints. Specifically, some of the data out of Eswatini shows 130,000 chief complaints, all written in English, some longhand in English, which is an immense amount of data. The problem that we're trying to solve is that we don't know how to advise SEMU or their 911 system to be able to improve their education, which areas, which kind of patients they see most commonly, what kind of chief complaints are prioritized need to be prioritized amongst their educational groups. Are they different times of year? What should they focus on? We don't know. We don't have categories for understanding chief complaints in a global setting, and it obviously would differ depending on your setting. So we've taken a look at both Brazil as well as Eswatini to understand from these chief complaints, can we categorize these words as text that we're receiving to be able to understand what kind of patients are presenting? Next slide. So there's a 5-step process, and I'm not going to go through the whole entire process, but to give you an idea, we start out by obviously assembling the data. 130,000 chief complaints is massive. And each one of these chief complaints, especially if it's in sentence format, you have to pull out the important parts. This is essentially called tokenization. I could say bleed 7 different ways: bleed, bleeding, bloody, bled, all of the different ways, but it really only means one thing. And so you would tokenize it and then weight that to see how frequently it is occurring and amongst which combinations of words are occurring together. So this is the assembly, cleaning, and tokenization period. Next slide. We then end up visualizing it. So what words end up coming together, how frequently are specific words used? Next slide. And then into a category development stage. So this is where we do a latent semantic analysis and understand the categories. specifically, each of these dots are one of the words, and the links between them are how closely some of these words occur together. And if you see the small circles, these words frequently occur together. So the word cloud you saw on the prior slide, which was women, bleeding, primigravid, those kind of words, are this cluster that is pointed out here. It's a chief complaint cluster that has to do with vaginal bleeding in the peripartum time period. Next slide. So natural language processing will give us a lot of information specifically, and it's able to organize that into something like chief complaints, which can guide our education and protocols. But there's a lot of other information that we've had globally that's really been very important that has to do with your geography, your space. And specifically for pre-hospital care in a global setting, we've thought a lot about spatial relations and how space might impact your clinical outcome, your access to care, where care is associated within your environment and how you access it. So we specifically in our group use GIS for three things, really to understand the epidemiology of whatever the illness is that you're dealing with in that location. And I'll talk about that in a second. To identify hotspots to see if there's something from a preventative standpoint we should do, or taking a look at sociodemographics or social determinants of health. So first, let's talk about overall epidemiology. These are two examples. We started working in Brazil and have these massive data sets that Brazil creates because they have a nationalized health system that's parallel to their private healthcare system. They're able to understand exactly every patient interaction with their health system and understand if it was a traumatic brain injury, if it was a hospitalization, if it was a death, et cetera. We also overlaid that over the time period, over a decade time period, as well as understanding the growth in types of vehicles that were being used. So on the bottom, you're going to see the blue areas are low risk traumatic brain injury deaths surrounded by other low risk areas. So not a lot of people and or not a lot of traumatic brain injury deaths. And then the red areas that are starting to pop up, you can tell in the center of the country, are areas where new traumatic brain injury deaths are occurring. Now, knowing the country, knowing the health system development, especially in that area right in the center of that last panel, this is an area that was a large amount of construction, a large amount of new roads, and no health system development where it was needed. So to be able to understand over time where epidemiology is and what is happening, and link that with current events from outside, it allows you to think sort of at a systems level to be able to link things that are important, like your Ministry of Health with your Ministry of Transport. So communication can happen at that level to improve outcomes. Same thing occurs within the health system. The second group of panels that we have here on your right is understanding reperfusion centers. So their hospital systems are different from ours. They have truly a cardiac care hospital that has a reperfusion center for acute MIs. But your access to that center is very different depending on where you live because it's not universal. And so we were able to take a look and understand how your distance to your reperfusion center really is able to impact your outcome or impacts your outcome, and then able to inform health system development to improve locations of where they need either new services or to improve services that are currently available. Next slide. Another important area is hotspots. So for injuries specifically, road traffic injuries globally are increasing exponentially. There's not a lot of really good data sets. Police data isn't always complete. Understanding the locations of where crashes are occurring is very important to do preventative environmental improvement, but we don't have that data globally. So by basing, using whatever data we do have and understanding hotspot analyses from these two examples, or as examples, we can improve that science and improve prevention of road traffic injuries. The example on the bottom, we use two different information sources, one survey-based information of those who use the roads most frequently, and another hospital level data, or sorry, police level data to be able to inform where the crashes are occurring. A lot of times, some of the information is the same, but some is not the same, showing that either there is less understanding of the road use by the road user, or there is incomplete data from the police. That being said, this can easily guide Next areas of prevention and understanding of police where they might need to focus on prevention initiatives for the region. And that information is in Galle, Sri Lanka, and some information also in Kigali is on the right side in terms of the road traffic injury hotspots. Next slide. Excellent. So the last one is talking a little bit about geospatial and economic indicators for predictive modeling. So some of the work that we've worked on in Brazil is using a prediction model about who will have a preterm birth. A little bit outside of emergency medicine, but not really when you think about women who have a preterm birth are far more likely to utilize our services, which we would like to avoid. Having a normal term birth outside of our doors would be preferred. But specifically in the Brazil health system, where you can link people to a specific primary care location and improve and increase their preventative services if you identify them of being at risk, it would be a great way to be able to identify women and increase your preventative care. So we created, using a lot of data that they currently have, we created an algorithm that can predict who is likely to have a preterm birth and what time period, what week they might have a preterm birth. And so to be able to start their improved public health and preventative services before that. Part of the thing that we found that was very impactful was where they lived, what was around them, who was around them. And therefore information like geographic information systems can impact also these kind of predictive algorithms to improve our care. Some of the things that are also important is the services that you're able to access. So as seen on the map on the bottom, some of the services have good process. They have the things they need, they have the equipment they need, they have the personnel, and others don't have as much of a good process. And therefore outcomes, specifically preterm birth outcomes, are going to be greatly impacted by the services and availability of services that you're able to get. So these are specific examples of both socio-demographics as well as structure of health services and the work process that they go through for these preventative interventions, and how that can have a direct impact on outcomes that we look at. Next slide.
All right, so thank you, Dr. Staton. My name is Sangil Lee. I'm a clinical associate professor at the Department of Emergency Medicine at the University of Iowa, Harvard College of Medicine. So I'll be covering the clinical prediction rule and machine learning. Many of the existing clinical decision rules, for example, pulmonary embolism rule out criteria, or we call it as a PARC rule. And another example would be a heart score. These scores were developed and validated using the prospective cohort design from multi-sites and used scoring system or probability estimate. The key to these rules are that they are easy to interpret and they are generalizable to patients that we are caring for. So how is machine learning different from a conventional clinical decision rule? Allow me to share this opinionated table showing a contrast of clinical decision rule and machine learning. Although it is an attractive option, machine learning raises an issue of interpretability for some. This is a critical concept that the patients and clinicians rely on to convey information. If data analysis stays in a black box, clinicians may hesitate to follow the machine learning prediction for a certain condition. There's an exception. One example would be that when the interpretation of imaging study is of interest. In the case, they could use a neural network, which is a type of unsupervised, uninterpretable machine learning. Some machine learning algorithms are supervised, but they are quite difficult to interpret. And one example would be support vector machines. Some models, such as logistic regression and decision trees, are much easier to understand. And many models have functions to demonstrate variable importance. This is from our ongoing study. We are interested in predicting delirium, which is a common brain dysfunction in older adults. Using the variables from emergency department, we built a model that AUC, or the area under the curve, which is a general marker of a prediction performance. AUC was about 0.69 to 0.77, which is not bad. This number may be interesting to the researchers, but probably not that interesting to the clinicians or patient. So in order to interpret it, we estimated the probability for a particular case scenario, so it can be interpreted in the clinical care setting. With that, I will transition to Dr. Lim again.
Thanks, Sungul. I'm Alex Lim-King from Duke University. And as background, I'm interested in acute coronary syndrome and biomarkers. But I also work with some infectious disease doctors who work in the emergency department in sepsis and precision medicine. And one day they pulled me aside and said, you know, for all the work that we do, if you just substitute the word acute coronary syndrome for sepsis, you could probably do a lot of the work that we're doing. And that's how I got interested in this topic. So going from the geographic scale of what Catherine was talking about of healthcare systems as large as the country of Brazil, we're now got to zoom down into the level of molecules and talk about precision medicine. Precision medicine is a popular term, and like many terms that get perhaps overused, it can be broadly defined as providing treatments based on a highly individualized analysis of an individual patient. Of course, that's basically all of medicine if you take it a definition that broadly. So typically when this term is used, it implies the use of in-depth or big data sets, sort of like what we're talking about. So on the left-hand circle, and more specifically, what people most often mean are some form of omics analyses, which I'll talk about, which would be the right-hand circle. So when we talk about these omics analyses that you may see used a lot, I like to use the phrase systematic molecular phenotyping for that. And I think that's a little more descriptive. And again, when you use the term precision medicine, there are some out there parenthetically who would include things like environmental data or social determinants data as types of precision medicine also. But again, broadly speaking, most people are talking about this kind of molecular systematic phenotyping. And a related but distinct concept that's related to a lot of the modalities of analysis that we were talking about earlier, such as AI, machine learning, deep learning, is this concept of systems biology. And it's something that is possible when you use sort of big data and omics and precision medicine approaches, in that the researcher is less concerned with identifying a single deterministic biomarker, whether it be a protein or gene, but rather identifying the holistic pattern or perhaps even a body system that's involved, like complement activation, for example. And it's different from a traditional reductionist approach, which posits that we need to find the single biomarker or molecule that's important for predicting or causing disease and therefore acting on it. Next slide. So when we talk about omics or systematic molecular phenotyping, when you look at the activities of a cell, very simply diagrammed here, there are multiple layers and levels at which you can analyze an entire class of molecules from a single sample from a patient now. And that's where the technology and the data analysis has advanced, where it is now quite simple from a single patient peripheral blood sample, for example, to analyze an entire class of molecules. And so the suffix ome, O-M-E, has come to mean an entire set of molecules that can vary between individuals. Thus, genome means the study of all those specific genes, proteomics, the study of all a specific class of proteins, and so on. And so that's where the term omics is now wide-ranging and used in a lot of different contexts, but that's essentially where it came from. And an output from one of these types of analyses can be as high as thousands and even hundreds of thousands of different molecules, whether you're talking about genes, microRNA sequences, proteins, or fatty acids is just an example. And so there's an endlessly growing body or new categories of omics being produced every day, it seems. I'm just going to highlight a few specific modalities that I think might be of special interest to emergency physicians. The first is transcriptomics, and transcriptomics really refers to analysis of RNA sequences, and particularly messenger RNA sequences. There's been a lot of discussion about mRNA, obviously, in the last year. And as we've learned mRNA technology through vaccine technology, mRNAs tend to be very transient, transiently present, and degraded quickly by the body. And so that means that the levels of particular mRNA sequences can change rapidly in particularly transient states, such as we're interested in studying in emergency medical or in emergency medicine. And so I think that's an area of particular interest for emergency physicians. To move on, another form of omics is microbiomics. I'll just briefly mention it was actually featured in one of the plenary abstract sessions in SAM. So shout out to Carlos Camargo and Kohei, who presented some data that used microbiomics from the airway of infants. But microbiomics refers to cataloging the entire diversity and quantity of bacterial species, and it does that through genetic sequencing of those bacteria. So it's a very promising, understudied field in emergency medicine. If you're talking about gut microbiome, it can be as simple as swabbing someone's mouth and or the other end of the GI tract to get those samples, and can be a very simple way to get sampling. And then the last category I'll just call attention to is the prefix pharmaco. So when you add the prefix pharmaco to any of these other omics modalities, it simply means studying whether a specific drug works for a condition or is more likely to be more toxic dependent on these omic analyses. And so classically people think about or talk about pharmacogenomics, meaning will a drug work particularly well or be particularly toxic for people with certain genotypes. And there are well-known examples relevant to emergency medicine related to the metabolism of drugs such as Plavix or warfarin, for example. So that's a big ongoing area of study and I think relevant to emergency medicine. Next, please. So for emergency care researchers, there's certainly an opportunity to get involved, and it can be as simple as this kind of workflow that we're very familiar with, at least for the first step. Take traditional study methods of doing diagnostic biomarker work, for example, which involves getting sample collections from patients with the condition of interest, and take these samples next to your team science or black box. Okay, so most academic centers now, if you look and ask around, have core service-oriented cores who will perform omics analyses for you if you show up to them with your samples. Of course, you should plan this out a little beforehand. Don't just literally show up at their door. But this is now a thing where at a level where most academic centers have people who can do this for you and conduct these analyses. So you do not have to, learn Sanger sequencing or buy your own Illumina device. And by working with these folks, you can even expand on existing samples that already exist and perhaps expand your research portfolio. I think the third step, which is also important to highlight, and again, referring back to the multiple modalities of analysis that we've referred to already, is dedicated data analysis. This is not, because of the number of molecules you can generate from a single sample from a patient, and this is what we would call high dimensional data, you definitely need specialized statistical analysis techniques along the lines of what we've already talked about. And so precision medicine is just another example of how to use these specialized techniques. Next slide. So just to run you through a personal example, I was interested in studying biomarkers, as I said, in acute coronary syndrome, and I had a existing repository of samples that I collected in the following manner. So we had patients, this goes back a bit, so we were still running a lot of stress tests in our emergency department. So I was able to enroll patients and get blood samples on them before and after their stress test that they received as part of their usual care. Next slide. So I take these samples. I found 7 patients who had abnormal stress tests and age and sex matched them to 7 controls who didn't have ischemia on their stress test. just to see if we could identify differences between these two groups as a pilot work. And so this work was funded by the Emergency Medicine Foundation to examine transcriptomics, so microRNA sequences, using sort of standard platforms like the Illumina HiSeq. Next slide. And we've talked about many other more sophisticated ways to analyze this kind of data, but this is a basic sort of visualization of an output of one of these types of analyses. So if you just focus on the left-hand side, for example, out of approximately several thousand possible microRNA sequences that were analyzed, these are the ones on the left-hand side column that you can see that changed differentially or were different at baseline between our cases and our controls. And so this heat map just demonstrates by color sort of the differences in these different microRNA sequence levels. And of course, because we analyzed several thousand, there were, on the order of several dozen that were significantly different at a p of less 0.05. And so this isn't the definitive sort of test or analysis. Of course, it's a pilot work, but it just demonstrates how you can identify differences in both the patterns and individual microRNA sequences between these two different phenotypes. And on the right-hand side, you can see the same analysis only looking at what I call the stress delta biomarkers. So the changes in these levels between baseline and after the stress test. Next. So that, I think I'll turn back over to Sangwoo to bring us home.
Yep. So here's our summary. AI, machine learning are becoming a part of the common research and practice tools. AI machine learning will continue to harmonize with the human task in healthcare. And I think the third piece is probably the most important. You don't have to do this by yourself. You should reach out to your colleagues within a department, within a campus, or within other domains. So that concludes our session. And I think we have a couple of minutes if there is any questions, comments. I think we should be able to answer a few. If I cannot get to it, or if we cannot get to it, I'll make sure to follow up later.
Yeah, there was a question from Michelle Lin in the chat. What are the opportunities and barriers to applying ML to improve diagnostic accuracy using EHR data?
All right. Who wants to answer this question?
I guess I can take a little bit of it. So I mean, one key barrier is just familiarity with the EHR data and all of the pre-processing that goes into that. I think a lot of people don't either realize or just how much kind of pre-processing. What I mean by pre-processing is taking out the variables, cleaning them to some degree, fixing them up, getting them kind of ready to put into a machine learning model. The other big area I think that people always have questions and concerns about is data quality. And I think that we're continuing to struggle with that as well. And then as far as like opportunities, I always look at it, opportunities are where we have really complex decisions that we need to make that have multiple data points that need to be incorporated, and that we don't have really good feedback on our predictions that we make. So I tend to think that we get really good at figuring out whether people have appendicitis or colitis or something where we have feedback from CTs and other things. But for those, for those outcomes that when patients leave the emergency department and we don't really get all the time good feedback on it, it's hard for us as kind of our own kind of machine learning selves to be able to kind of learn from that system. And so those are opportunities to really advance machine learning in those spaces.
Yeah, I think that this comes up more and more in discussions around AI and ML is really the data stewardship and the work you have to do before you run the models, and then even continuously learning systems, which goes to the question Judd Hollander brought up, which is when people and vendors see AI and ML products, how will they have any idea how they perform and what they really do to impact outcomes? Aren't they going to consistently be changing and making like evaluation pretty difficult? Or maybe we're just going to have to switch our framework to sort of continuously evaluating these things. What do you guys think about that?
I think some folks are making inroads about the portability and particularly of machine learning algorithms, as well as sort of uncovering what's in the black box. That's becoming increasingly important for that exact reason, not only to demonstrate, what's behind the thinking, but also for dissemination. Catherine, you were going to say?
Yeah, exactly that. I think the point might switch to implementation, dissemination, understanding of this, how this is implemented, how it impacts everything around it, how it does have to continuously adapt and therefore continuously be improved along the way too. So continuous evaluation as well.
All right, it looks like we've run out of time and need to wrap up, but great job, speakers. That was a wonderful session. Obviously, lots of thought-provoking questions coming up. Everyone, I'd remind you to look for the speakers' Twitter handles, continue the conversation online after this, or shoot some emails based on their contact information. Great job, everybody. Thank you so much for being here.
Thank you so much.
Thanks, everybody.
Everyone.